Urinary tract infections, or UTIs, are the most common type of healthcare-associated infection in the U.S. However, the prevalence of asymptomatic bacteriuria, which does not require treatment, makes the diagnosis of true UTIs challenging. This is especially true in catheter-associated urinary tract infections, or CAUTIs. CAUTIs occur in persons whose urinary tracts are currently or intermittently catheterized, or have been catheterized within the previous 48 hours. The duration of catheterization is the most important risk factor for developing catheter-associated bacteriuria. By 1 month of catheterization, almost all patients will have developed bacteriuria, the vast majority of which is asymptomatic and does not require antibiotic therapy. Inappropriate treatment of catheter-associated asymptomatic bacteriuria undoubtedly contributes to the growing reservoir of multi-drug-resistant organisms in skilled nursing facilities and hospitals worldwide. In the segment that follows, we will review recent IDSA guidelines highlighting primarily the diagnosis of CAUTIs. First, how should CAUTIs be diagnosed? According to the current IDSA guidelines, a UTI is defined by fulfilling all 3 of the following criteria. Number 1, the presence of signs and symptoms compatible with an UTI. Number 2, no other identifiable source of these symptoms. And number 3, significant bacteriuria, defined in this case as at least 1,000 CFU per ml of one or more organisms from an appropriately obtained urine culture. The difference between asymptomatic bacteriuria and urinary tract infections in this population is the presence of symptoms attributable to the urinary tract with no other identifiable source. Patients with CAUTI rarely present with signs and symptoms classically associated with UTIs, namely dysuria or frequent urgent urination. The signs and symptoms consistent with CAUTI include 2 groups. 1, systemic symptoms, such as new onset or worsening fever, rigors, altered mental status, malaise, or lethargy with no other identifiable source. And 2, evidence of local infection of the urinary tract, including flank pain, CVA tenderness, acute hematuria, pelvic discomfort, dysuria, and in those whose catheter have been discontinued, urgent or frequent urination, dysuria, or suprapubic pain. In patients with spinal cord injury, increased spasticity, autonomic dysreflexia, or a sense of unease could also be considered UTI symptoms. Unfortunately, many of these symptoms are not sensitive or specific for bona fide UTIs. Thus, the diagnostic burden falls on the clinician, who must rule out other potential sources of the patient's presentation before concluding that his or her patient has a CAUTI. You may have already noticed that urinalysis results are not included in the UTI diagnostic criteria. This is because UA results can be misleading in many cases, especially in those with indwelling catheters. The IDSA guidelines make a few specific points regarding the interpretation of UAs in this setting. First, pyuria of any degree is not diagnostic of CAUTIs and cannot be used to distinguish between catheter-associated asymptomatic bacteriuria and a true CAUTI. Conversely, the absence of pyuria indicates that an alternative diagnosis for a patient's presentation should be strongly considered. Second, cloudy or foul-smelling urine should not be used to diagnose CAUTIs. Remember, we expect that almost all patients will develop catheter-associated bacteriuria within 1 month of catheterization. The daily rate of developing catheter-associated bacteriuria ranges from 3 to 8% per day according to different studies. Also remember, the difference between asymptomatic bacteriuria and CAUTIs is the presence of symptoms without any other identifiable source. In order to confirm your suspicion of a CAUTI, you must obtain an appropriate specimen for culture. According to the IDSA guidelines, obtaining samples from the indwelling catheter in patients with short-term catheterization, being that of less than 2 weeks, is acceptable. These cultures can be obtained by sampling through the catheter port using aseptic technique or puncturing the catheter tubing with a needle or syringe. However, this is not the case for long-term indwelling catheters or those that have been present for greater than 2 weeks. If the patient with symptoms suggestive of CAUTI still needs an indwelling catheter, urine cultures should be sent from a newly placed catheter prior to starting empiric antibiotics. In patients in whom infection is suspected, who had a catheter removed within the last 48 hours, a midstream urine sample should be collected. Collecting appropriate urine samples will allow you, the clinician, to accurately interpret the culture results. The patient in Case 2 was diagnosed with a CAUTI because 1. He had symptoms consistent with a local infection, namely bladder tenderness, in the setting of 2. Other nonspecific signs of infection, namely fever, tachycardia, leukocytosis, without evidence of another identifiable source, and 3. He had significant bacteriuria isolated from an appropriately collected sample. His urine culture was performed on urine that had been collected from a freshly placed catheter. How long should CAUTIs be treated? There is little literature to guide decisions regarding duration of therapy in patients with CAUTIs. However, current guidelines support 7 days of therapy in those patients with prompt resolution of symptoms. In those with a delayed response, 10 to 14 days of therapy is recommended. These durations do not depend on the continued need for catheterization. In this patient's case, his delayed response was likely due to the bug-drug mismatch, meaning he was being treated empirically with an antibiotic that did not adequately cover the E. coli isolate cultured from his urine. Thus, a 7-day course of therapy is likely still an option for him if he improves rapidly on ciprofloxacin. Of course, the need for continued catheterization needs to be addressed regularly to prevent the recurrence of CAUTI.